Hello, my name is Rich Bassett. I'm the flight paramedics for Lehigh Valley MedEvac, and today we're going to be talking about hemodynamic monitoring, specifically to the transport environment. Just to review the objectives that we hope to cover today: preparing for the invasive line monitoring system, indications and utilization for an arterial line, indications and utilization for a CVP line, indications and utilizations for a Swan Ganz, or otherwise known as a pulmonary artery catheter line, potential complications of invasive lines relative to the transport environment, and also discuss the 4 classifications of cardiac-related shock. For invasive line preparation, it's basically starting from scratch. Before you even get started, you'll need to gather all your supplies for your monitoring system. So there'll be a 500 bag of normal saline, pressure infusion bag, disposable transducer pack, and which will include both the pressure tubing and the transducer, solid caps to replace the open caps on the stopcocks. Usually the solid caps will be included in the trans pack or the transducer kit. Cables to conduct the transducer to the monitor, which you find in our IV pump bag here at MedEvac, and means to secure the transducer to be level with the phlebistatic access. To start with, and hopefully I'll have a video to go along with this off of YouTube or something along those lines, we'll place the IV saline bag in a pressure infuser bag, attach the pressure tubing, close the most proximal clamp to the IV bag, inflate the pressure infuser bag to the green zone, which would actually be about 250 to 300 millimeters of mercury on the gauge that's on the bag. It depends a little bit on the brand of the bag. And this will deliver approximately 3 milliliters an hour through the line it is connected to when everything's opened up. For smaller pediatric patients or infants, consider the use of an IV syringe pump in place of this setup. In other words, in place of the pressure bag. Prime the pressure monitor tubing. Please make sure that there is no air in the line or the stopcocks. Remove as much air as possible from the IV bag. This is especially important in the transport environment. This can be done a couple of different ways. It can be done by opening the roller clamp by spiking or unspiking the bag prior to inflation, inverting your tubing in the bag once pressurized, and then opening the clamp to purge air out, or using a blunt needle to vent out the air after pressurizing from the bag itself before opening the roller clamp. Replace all the hollow stopcocks with solid caps. Be sure all the tiny air bubbles are removed by forming a meniscus out of fluid at the open end of the stopcock before replacing each cap. So before we actually put the new cap back on, we make sure there's a little meniscus of fluid on top so there's no little air bubbles. The solid caps are extremely important in our environment. It's very easy for a stopcock to be bumped into the wrong position, and that could result, especially like off an arterial line, in an unrecognized blood loss in a well-packaged patient. In other words, we might even see where that stopcock is, get to where we're going, and find a big puddle of blood if we're not careful. And then if we want to attach our monitoring cable to the transducer, from the transducer to the monitor, and then place the transducer at the phlebistatic access as pictured on the following slide. In the transport environment, securing the transducer to the patient's arm is usually the most desirable to maintain the same position relative to the patient's right atrium. Now in the hospital, you normally won't see that. They normally have like a leveling stick or maybe even a laser to line it up perfectly off an IV pole to the phlebistatic access. In our environment, especially in a helicopter, that's just not possible or practical, even in the ambulance. Just as a reference, that's where the phlebistatic access is considered, and it's the mid-axillary line where it intersects with the fourth intercostal space. When to zero the line, open the system to air by turning the lever of the stopcock closest to the transducer towards the patient. And just something to keep in mind with the stopcocks, they can be confusing, whether we're using them for umbilical lines, for transducing pressure lines, whatever. Just remember the shutoff, whichever way the lever is pointing is where it's shut off. So when it's shut off towards the patient, that means there won't be any blood backing up into your line. Once you have it shut off towards the patient, then you can remove the cap from the port. Press the 0 button on the monitor to correspond to the line you are zeroing. That monitor will display a message that is zeroed after a couple of seconds. And then you flush the line to form a meniscus again on the open end of the stopcock. Close the system there, then put the cap on. And it should be a solid cap, especially at that point. Observe and monitor for appropriate waveform for the type of line being monitored. So there are different types of appearances of the waveforms. You expect an arterial line to look one way. You expect a CVP line to look another. An arterial line and indications and how they're used. There's two main purposes, and the first one is it can constantly monitor your blood pressure. It's systolic and diastolic pressure you usually select, as well as a mean arterial pressure. So that's something you can constantly be keeping an eye on. And these are great for when you're titrating like your vasoactive medications, whether you're trying to raise the blood pressure, lower the blood pressure. Maybe you're given cardine and you want moment by moment, see how far you're dropping your pressure so you're not dropping it too low so you can titrate it. Maybe you're titrating on the opposite end, some Levofed, and it gives you almost immediate response to your arterial line. It's also, especially for the in-hospital folks, it's an available source for ABGs, and even more, even other blood work, can be drawn off of that. In the hospital, may not see so much in our environment, but here at Lehigh, they usually have a safe set on there, so they can draw off like 10 cc's of blood, then draw off their lab sample, and then re-inject that blood. And that way there's not this reaccumulating blood loss. It's also a lot safer for the provider who's drawing the blood off the line, and they're not constantly have to waste it. It's a nice closed system. There are two main reasons for CVP, and for the sake of this discussion, we'll also refer to it as a CVP even as a non-monitored triple lumen catheter for here. A triple lumen catheter is capable of delivering multiple medications and fluids and blood products through different ports in the same line. In addition to being able to deliver all these different medications at the same time, it can be a safer way. So like a lot of people would prefer to be given like Levofed, for example, through like a central line, through a triple lumen. Or maybe even potassium might be more comfortable for the patient if it's given through a triple lumen, if that's available. So there's a distal, medial, proximal port to the triple lumens. And something you need to keep in mind now, it looks like a big fancy line, but if you really need to get fluids or blood fast, and it's a choice between hanging it on a triple lumen line, one of those ports there, or let's say a short 16 or 14 gauge IV, that IV, even though it looks a lot simpler, is actually going to function a lot faster and better for those cases when you really need to push in the fluids fast or the blood fast. Just something to keep in mind. A triple lumen catheter, the second reason to have one, it can also monitor central venous pressure, or CVP. Some people refer to as a CV pressure as an RA or right atrial pressure. So if you hear those terms, it's all kind of the same. Right atrial pressure, CVP, central venous pressure. The CVP pressure gives a provider an indication of the preload going into the right side of the heart. It may be useful in determining a patient's fluid status, but it's not the end-all diagnostic tool. You have to correlate it with other things. What's the patient's blood pressure? How's their urine output? That type of thing. What's their whole clinical picture? Do they look dry? So normally, if it is going to be used for monitoring purposes, a triple lumen catheter will be inserted through the internal jugular vein or subclavian vein, so it can be used for the CVP monitoring. It can actually be transduced then. there's a little discussion out there. We often see when we pick up at referring hospitals a triple lumen inserted through a femoral vein. And a lot of sources question whether we can really use that for CVP readings. It might be okay maybe to trend. It's certainly okay to be giving, blood, fluids, different medications, and all that type of stuff to administer things. But it might not be the best place to try to get CVP readings. It's just too far away, most people feel. The normal values, these are somewhat variable. Also, the normal values can be 2 to 6 millimeters of mercury or 4 to 8, depending on which resource you're going to use. For the mechanically ventilated patient, we'd want our readings to be about 4 millimeters higher than the normal value. So if you think that your normal value for a CVP line should be 4 to 8, that would be like your desired value. If your patient's mechanically ventilated, you would hope that value would be 8 to 12, for example. Your distal port is typically used for invasive monitoring to get your CVP reading. And it's often the case where all the ports will be used for fluids or medications, but you'll just occasionally check your CVP. It's actually kind of hard to get a constant CVP reading, to expect to get a constant one like an A line, especially in the transport environment. So you might need to momentarily turn off medications or fluids that are going into your distal port. Go ahead and transduce the line, open it up to that, and then obtain your reading, see where you're at. On the left there is just a picture of a triple lumen line with 3 ports. An example of how to use it to determine a fluid status. I guess the more classic one would be like maybe a septic patient that has a low reading, has a low blood pressure and a low CVP reading with correlating clinical data, such as low urine output. It might give you an idea, well, that patient probably needs some more fluid then. Now, if the same patient, let's say we're a few more hours down the line, they've gotten a bunch of fluid, maybe let's say they got 4 liters, they kind of got the standard 4 liters of fluid for your septic patient, and they still have a low BP, but their CVP reading is elevated, well, maybe instead of giving more fluid, maybe you want to start a pressor at that point. Maybe, a lot of people would say maybe start some levo, get some levo going. So just looking at the CVP reading by itself isn't really the end-all in diagnostics, but you kind of, equate it to your whole picture. Your Swan-Ganz line, otherwise known as a pulmonary artery catheter, can be used for different reasons. In some ways similar to a CVP line, but with increased compatibility for monitoring and less useful for multiple medications. Medications really only can be infused through the proximal port, a port that is also used for right atrial or CVP pressures. Medications can never ever be infused through the distal port, also known as the pulmonary artery port. Imagine, if you could just imagine like the consequences of infusing a pressor directly into a pulmonary artery, especially something like Levofed. If you injected that directly into the pulmonary artery, think about what that's going to do for your pulmonary circulation. If the introducer catheter, often known as a cordis, is left in place with your Swan-Ganz line, this is a port that you can easily use for fluid or blood product infusion, and actually might be your best bet for rapid infusion. It's a very wide diameter catheter. It's in a French size. You can give a lot through that. And it's just a picture there on the left, shows the introducer or the cordis, and that's actually what the Swan gets fed through. The subclavian or the internal jugular would actually be cannulated with that first, and off to the right of the introducer there you can see your extra port that maybe you could hang some fluids or blood products with. On the right there is the actual Swan-Ganz catheter, showing all its different ports. Also has the syringe there. One of the main reasons the Swan-Ganz catheter would be used is to measure the pressure in the pulmonary artery. If it's properly placed, the tip of the catheter will be in the right pulmonary artery, actually inside the pulmonary artery. And a pulmonary artery pressure is obtained through there, and it gives an idea of the right ventricular function and pulmonary vascular resistance and left atrial filling pressures, and is measured when the balloon is deflated. When the balloon is inflated, is referred to as a pulmonary capillary wedge pressure, or simply as a wedge pressure. When you hear people talk about a wedge pressure, that means they got that pressure when the balloon was inflated, and it's very important to know, especially in our environment. And your wedge pressures reflect the preload to the left side of the heart. A wedge pressure is performed by inflating 1.5 cc's of air from a specifically designed syringe for that balloon. You don't want to have a 3 cc syringe hooked up to that. It looks like one, but it's not. It only goes back to 1.5 cc's. You don't want to overinflate that balloon and pop it. And then as soon as you get your reading that you need to remove all the air from the balloon, and this is very important. This is something we probably, on a rare occasion when we do see a swan line, might not be something we need to do during transport, especially transport. And maybe that could be done even before the patient's moved. Maybe you have the ICU staff. Chances are we're not going to be picking up the somebody with a Swan-Ganz line out of an emergency room. I'm not saying it's impossible, but chances are we're picking up a pretty sick patient from somebody else's ICU if they have a swan in. So maybe that's something that can be done while things are very controlled. You can even get some of your other numbers maybe that might be helpful before you're hooked up to their monitor that you can get off of theirs, like a direct cardiac output or cardiac index, that type of thing. These are just an example of some of the pressure waveforms that we would expect to see. So your right atrial pressure, which is also your CVP pressure, and your pulmonary artery wedge pressure, those waveforms look kind of the same. The values are a little different. The values in the wedge pressure are actually, maybe a little bit more than a right arterial pressure or CVP pressure. But the thing you want to remember, when you're monitoring your pulmonary artery, your swan line, you should be seeing your pulmonary artery pressure waveform, which looks not all that indifferent from a standard arterial line pressure, the waveform itself. The values are a lot different or a lot less, but it looks pretty similar. There's a dichrotic notch, it has a pretty nice waveform. But if you see that go to what looks like what a CVP reading will look like, or a pulmonary wedge pressure would look like, that's like a true emergency at that point. Like I said, it's not exactly the same, the wedge pressure as a CVP reading, but if all of a sudden it looks like that, that means that your catheter might have inadvertently wedged, and it's very important that you recognize that, even if you don't recognize the exact values without looking up a reference. Some other indications for a Swan-Ganz line, it can get a cardiac output, which is just simply the stroke volume times the heart rate. And then you'll hear people talk about a cardiac index, and that's just a patient's patient size corrected stroke volume. Indirectly, the Swan-Ganz catheter can also measure systemic vascular resistance by the following formula, and also can get pulmonary vascular resistance. So to get your systemic vascular resistance, it's just a formula that involves your mean arterial pressure and your CVP divided by your cardiac output. To get your pulmonary vascular resistance, that's where you actually have to get a wedge pressure to be able to do the math for that. So that's something you want to keep in mind. And that's something that needs to be calculated out. Now, why is that important? Probably not terribly important in our environment most of the time, especially for how often we're taking Swan-Ganz lines. But for somebody who's getting ready to take one of those certification tests for flight nursing, flight paramedic, I would probably know some of this. If it means saving a copy of this slide on your computer, if it means taking a picture of this slide with your phone, there's a good chance some of this is going to be on some of those exams, either in some type of scenario or just an outright question. But know what you would expect your CVP to be, your cardiac index to be, your systemic vascular resistance, your pulmonary vascular resistance to be, like, for example, your right heart failure, your left heart failure, a tamponade, hypovolemia, cardiogenic shock, sepsis. So we talked a little bit about the sepsis. You would expect a low CVP. If they went through all the trouble to have a swan line on a septic patient, then you would also expect to see a pulmonary capillary wedge pressure, or just simply a low wedge pressure. You would also expect to see a low cardiac index or cardiac output, pretty much interchangeable terms. Also a low systemic vascular resistance, which means they're vasodilated out. Now, with the difference between that and maybe a cardiogenic shock, septic shock and a cardiogenic, they'll have a lot of systemic vascular resistance. They'll have a high CVP, they'll have a high wedge pressure, but their cardiac input or cardiac index or cardiac output will still be crap. So just kind of know some of the concepts between the different types of shock and know how they're going to reflect on your invasive line monitorings. You might not need this memorized, this whole slide, for every day you come to work, but have it as a reference, and especially know it going into one of those tests. I already made mention of some of the invasive line complications in the transport environment, but generally speaking, disconnection of lines resulting in blood loss or embolism. So if it's like a venous line, you could, in theory, get an air embolism. There's an increased risk of infection, risk of thrombus or embolus, especially if the flow is not maintained. So we need to make sure that's maintained all the time. And then here's the biggie that can kill the patient in a few minutes. Inadvertent wedging of the pulmonary artery catheter. I made mention whenever there's a wedge pressure taken, we need to be very careful before we take the patient and during our care, during the transport, that the catheter does not get wedged, that a syringe full of air does not go in. This can happen, and the worst, obviously, if it goes unrecognized. This can happen, maybe the catheter advances itself too far into the pulmonary artery or into a narrowing of the pulmonary artery. And it can also happen from the balloon becoming inadvertently inflated or not properly deflated, as I just mentioned. You must monitor pulmonary artery pressures if you're transporting somebody with a swan. It is not ever, 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 ever acceptable to take a swan line and not monitor it. If the patient ends up with an inadvertent wedge and it's not recognized, the patient will probably die. They'll start up with some frothy sputum. Their blood pressures chances are will go through the toilet. They'll infarct a big part of their lung. So don't ever get talked into from a referring facility. They say, we're just going to cap it. Just go. Get the patient out of here. It's probably because they're maxed out on pressors already. They probably gave some epi or did whatever for the patient to still have a heart rate, and they're probably trying to get the patient out before they die. In all honesty, don't ever, ever, ever take a capped pulmonary artery line or a swan line. It's got to be monitored. If at glancing at it, your waveform does change from the nice crisp waveform with a dichrotic notch, and now it looks like just that little barely bumpy little waveform that looks similar to a CVP reading, you know you have a problem. So most people would say try to be You got to work through the problem quickly. In our environment, especially if they're well packaged in the aircraft, that might be difficult. First thing we're going to try to do is maybe move the patient around a little bit, have them turn their head to the side, have them turn their head to the left side, might work, have them turn their head to the right. Try to deflate the balloon, make sure some air didn't get in inadvertently. A last ditch effort, maybe you have to withdraw the catheter. See where it's at the beginning of your transport. See if that catheter position changed at all. Document at the beginning of your transport where it's at. But you might need to actually withdraw the catheter. And you want to withdraw it so it's past the right ventricle. So if you only withdraw it like an inch or two, and now you see what looks like a V-tach on your monitor, that means the end of the catheter is whipping around in the right atrium, the right ventricle, and can cause an arrhythmia. And it needs to be pulled past that. You want to make sure there's still flow going through it, but it needs to be pulled back at least a few inches. I know that everybody might not be real comfortable with that, but if it's a choice between that and maintaining an invertent wedge, which will kill the patient, probably pulling back. Maybe try to call in right away as soon as you do it, but it might be a life-saving maneuver. I already talked about if the tip of the Swan-Ganz becomes dislodged out of the pulmonary artery and whips around in the ventricle, it will look similar on the tracing and possibly even on the EKG to a V-tach. It's not really, and I don't think anybody here is scoped to try to float it back into the pulmonary artery catheter. I'm sure we have some staff here that have seen that done and have seen these put in and are much more well versed than I am on this. But I don't think that's within our scope to try to reinflate the balloon and float one back. And of course, there's always the possibility of a thrombus or even an air embolus if the balloon ruptures. There's probably not a whole lot we can do about that, but it's just something, just throwing that out there as one of the possible complications. I made mention of the shock box. These are kind of like the 4 different types of cardiac type shock we might see. And we actually consolidated this off one of the other ones that we used, one of our other PowerPoint presentations that me and Tom Rothrock put together from somebody else's PowerPoint presentation. We consolidated it all in the one page. And it just goes through the 4 different classifications. And so for your type 1, you'll just have like maybe a normal cardiac index, but maybe you're starting to see a low to normal wedge pressure. So there's probably not a whole lot you're going to do about that. You're going to monitor the patient, some oxygen, some pain medications, maybe a little bit of fluid, some sedation. Your 2 would be a low to normal wedge. Might be volume depleted, some bradycardia, and this is where more like your right side heart failure. So some oxygen, some fluids, some things to make your contractility better, maybe decrease your afterload. Sometimes you might see for a balloon pump. Your type 3 is like a normal cardiac index and a high wedge pressure. And it's like a volume overloader. Kind of, if you could picture your typical CHF patient, especially before they go into a cardiogenic shock. So these are going to be like, your diuretics, your oxygen, enhance their contractility, maybe get their heart rate down some. And then your class 4 is going to be your all-out cardiogenic shock. So they're going to have their frothy sputum. They're going to have a low blood pressure. So you're going to want to actually decrease their preload, decrease their afterload. Probably going to need a balloon pump if they can't fix the problem. And so here's just basically your, to go along with the shock box, kind of added this in, your clinical presentation. I kind of alluded a little bit to each one. So for your class 1 cardiac type patient, there'll be no signs of pulmonary congestion yet. Your class 2 will be more your rails and the bases. You might hear an extra heart sound at the end in S3. Your class 3 is like your acute pulmonary edema, like your CHF patient. And then your class 4 is your cardiogenic shock. That's when they're overloaded with fluids and their blood pressure is low. And then when we talk about some of your treatment modalities, it's part of this whole shock box thing. When you're increasing your preload, you're giving some fluid, maybe some vasopressors. When you're decreasing your preload, you're giving diuretics, you're restricting their fluids, venous dilators, to increase your contractility, your dobutamine, dopamine, maybe calcium, dig, levo, epi, and then to decrease your contractility would be your beta blocker and your calcium channel blockers. So when you go back and it says, increase your contractility or decrease it, you can kind of go over here and just have an idea. Like I said, you might not need to memorize all this, especially those 4 different types, but if you just kind of remember the concept, what you would do for these types of patients, and definitely going into one of those certification type tests, maybe have this memorized up a little bit better. So pretty much in closing, completing admission by ground or air with a patient that has an invasive line is something that does not occur all that often for all of us. And when we're managing these patients, it's one of those rarely performed high-risk skills. You hear that kind of term or a similar term thrown around for stuff you don't do too often, and then when it's high risk on top of it, just makes the whole operation a little bit more risky. So I just want to remind everybody, there is invasive line training equipment at each air base, which can be utilized by the crew to stay proficient with at least the mechanics of setting up your monitoring equipment. Also, regular review of this type of material, not just this, but other material invasive lines, is highly suggested for all the crew members too. We just don't see it enough to be proficient with it every day. You go over in the cardiac ICU or place or even the regular ICU, medical surgical ICU, we're dealing with this stuff all the time. Yes, we get it during our clinical time, and I beg all you to take advantage of it during your clinical time that we have. But just taking the toys out and playing with them a little bit helps too. And that's all I have for invasive line monitoring in the transport environment. Thank you. All done.